Pleasure to talk to you about intracerebral hemorrhage and can we change the outcome in the FASTEST trial. I think the question we'd all like to answer is, can we find a treatment that works for acute intracerebral hemorrhage? And we already know the baseline factors that are clearly related to outcome, but of these, only growth of ICH and the resulting volumes of ICH and IVH are biologically modifiable. We also know that when hemorrhages get to a certain size, no matter if you can slow the bleeding or do anything, the patients do very poorly. They almost all uniformly die more than 60 cc's, and certainly nobody has a good outcome. We also know if we're going to slow bleeding, we have to do it within the first couple hours after onset, as this slide indicates from a pooled analysis of all the serial CT studies done with intracerebral hemorrhage. We do have a medication that we know can slow and stop bleeding, and that's recombinant factor 7A. It's the only medication, as I'll show you, substantially decreasing the bleeding and spontaneous ICH. It's easily and rapidly administered intravenously with a rapid onset of action and a half-life of several hours. It's already approved for other indications, but obviously not for spontaneous ICH. Recombinant factor 7A works in two methods. One, it works with tissue factor at the site of a vascular injury to form thrombin. It also sits on the surface of activated platelets and stimulates factor 10 to factor 10A, which also produces an enhanced thrombin burst, probably its major effect. And so it focuses its activity at places of vascular injury. This same benefit for forming clots also is its risk, because at other vascular surfaces where there's injury, you can also have clot formation that could lead to a myocardial infarction or a cerebral infarction. We had two pretty large trials with recombinant factor 7A. The first one, phase 2B, showed you could slow the bleeding and it improved outcome, and it was a dose-ranging study. The second showed a neutral result with primary outcome, but still showed that you could slow the bleeding. We then did a subgroup analysis that looked at those patients who didn't have really big hemorrhages, less than 60, didn't have a lot of IVH, and then we looked at time and age. And you see here that the likelihood of a good outcome was much higher when you could give it within 2 hours, and really independent of the age, at least in this analysis. We then, and this is not published data, looked at the subgroup of patients who would meet the criteria for the FASTEST trial, which I'll talk about. And we looked at, again, we took out the 60 cc's or more, we took out the big IVHs, and then we looked at time and age. And you see here that it's really not till you get within that 2-hour window that you really have substantial differences in outcome with the recombinant factor 7A with placebo, although you do see some effect in the younger patients, but that's a smaller group of patients. This slide shows the effect of therapies on ICH growth, and you can see clearly that recombinant factor 7A substantially decreases the risk of bleeding compared to some of the other treatments, although I would note that the blood pressure trial INTERACT 2, when the treatment was done within 3 hours, also was associated with a 3 cc's decrease in ICH growth. So what have we learned? We learned that most bleeding occurs in the first 2-3 hours. Recombinant factor 7A has the best evidence for slowing bleeding in spontaneous ICH, but it's very time dependent. The benefit risk for recombinant factor 7A is greatest in the first 2 hours. And about 5% of patients who get recombinant factor 7A will have an increased risk of serious arterial thrombotic events compared to placebo in the previous trials. But if we're going to replicate and surpass the time restrictions of TPA, we're going to have to spend a lot of time focusing on that time window so we can maybe get an effective therapy. But I don't think if we go longer, we're not going to be successful. And finally, controlling blood pressure and recombinant factor 7A could be a synergistic target. So the objective of the FASTEST trial is to establish the first treatment for acute ICH within a time window, and importantly, a subgroup of patients that's most likely to benefit. And the specific aim is to test the hypothesis that if we treat within 2 hours of onset in appropriately selected patients with spontaneous ICH, we will have improved outcomes as measured by the ordinal distribution of the modified Rankin scale at 180 days. It's a randomized, double-blind, efficacy trial of factor VIIa plus the best standard therapy versus placebo plus best standard therapy, which includes an INTERACT-2 target goal blood pressure of 140. We're including patients who have less than 60 cc's hemorrhages, no or small IVH, and age less than or equal to age 80, and importantly, treated within 2 hours of onset. How are we going to minimize time to treatment? Well, you've already heard one talk today about mobile stroke units and a trial going on there. This is going to be, I think, the second major trial within the MSU, and we're going to be looking again as a way of really minimizing time to treatment. We're also going to use exception from informed consent in the United States, and I believe this will be the first such trial in the United States for ICH. And then we're going to look at the improved acute treatment processes that we've already been putting a lot of effort into for ischemic stroke and see how we can also apply those to ICH. Patients will be assigned in a 1-to-1 ratio to IV recombinant factor VIIa or placebo at a dose of 80 micrograms per kilogram with a maximum of 10 milligrams. That's given over 2 minutes. Investigators and patients are blinded. We only require a baseline non-contrast CT, but we will collect CT angiograms if done, but not required. We plan to enroll 860 patients at 107 hospitals and 15 and counting mobile stroke units across the world. You can see the countries that are participating. Australia is a possibly because they're still finishing their tranexamic acid trials in ICH. The primary outcome measure is the distribution of the ordinal modified Rankin at 180 days, specifically modified Rankin 0 to 2, a 3, and 4 to 6, and that was with extensive conversations with the FDA. You can see our secondary endpoints also at 180 days, and as I mentioned, we will collect spot sign data, but only if the CTA is done as standard of care. Oops, went back. Primary safety measures of the study will be life-threatening thromboembolic complications during the first 4 days, and a significant life-threatening complication will be defined as development of acute myocardial infarction, acute cerebral infarction, and pulmonary embolism, and these secondary safety measures will be also looked at out to 90 days. So, can we overcome the time demand of ICH and have a successful trial in the first treatment for ICH? We're hopeful. But if we can't do it with factor VIIa within 2 hours, we probably are not going to be able to have an effective hemostatic therapy, but we're hopeful, and this is the group that hopefully will get us there. The NINDS has approved funding for the trial. We also have approved funding for the trial in Japan. Novo Nordisk is supplying the study medication. You can see the US PIs and our national PIs in the various countries. And we look forward to maybe having a positive result back here in 5 to 6 years. Thank you so much.